Good day, dear colleagues. And today on our lecture, we'll talk about allergic rhinitis, and talk about uh, symptoms of allergic rhinitis, diagnosis of allergic rhinitis, and treatment, and also about its impact on bronchial asthma. And first description of high fever, or how we say today allergic rhinitis, was done by Jock Boston in 1819. And Jock Boston described high fever about the beginning of middle of June in every year. We see the symptoms more often, high fever. A sensation of heat and fullness is experienced in the eyes. To this succeed irritation of the nose producing sneezing, and to the sneezing are added a further sensation of tightness of the chest and the difficulty of breathing. And what is allergic rhinitis? Allergic rhinitis is an IgE-mediated disorder of the nose caused by the interaction of airborne allergens with specific IgE type antibodies on the surface of mast cell. And IgE allergen interaction leads to the mast cell releasing and sensitizing a number of chemicals which then cause the surrounding tissue to become inflamed. And we'll talk about the most important mediators that release from mast cells. First of all, histamine, and also we'll talk about leukotrienes and some other mediators. If we talk about prevalence of allergic rhinitis in Europe, usually you can see that prevalence of allergic rhinitis is about 20%. And when we talk about undiagnosed allergic rhinitis, we think that about 40-45% of population suffered from allergic rhinitis. About 500 million people suffered from allergic rhinitis worldwide. And if you see prevalence allergic rhinitis in other countries, you can see that in Morocco it's from 20 to 27% in different areas. Tunis about 15%, Ethiopia 2%, Kenya 12%, Nigeria about 40%. And also must think about undiagnosed patients with allergic rhinitis also in this country. When we talk about prevalence of rhinitis symptoms, between 1 and 15% children in age from 6 to 7 years old have allergic rhinitis. Between 17 and 14 years, about between 1 and 40% also have allergic rhinitis. Low prevalence of allergic rhinitis we see in Indonesia, Georgia, and Greece, and high prevalence in Australia, United Kingdom, and Latin America. In adult, in different countries, prevalence rates between 6% in France to 30% in United Kingdom. Mean prevalence about 17%. Persistent rhinitis more common in adult than in children. So in adult we see symptoms of allergic rhinitis more longer than 4 weeks. On this picture you can see incidence different atopic disease, and we talk about atopic mud. And you can see that in the first period of life, we see development in children eczema. And after this, after 5 years, we see development of allergic rhinitis. And also in this period, we see development of bronchial asthma and development eczema, and then rhinitis and bronchial asthma, we called atopic margin. What's the function? Nose and nasal cavities. First of all, function of nose is the sense of smell and taste. It's very important function. Also, nose function a filter protecting the lung from particulate matter. And also, very important, act to warm and humidity air prior to entry into the lungs. When we talk about rhinitis, we must talk about different type of rhinitis. We can see patient with allergic rhinitis, non-allergic rhinitis, and mixed rhinitis. How often we see this group of patients? More often we see patient with allergic rhinitis, about in 43% of population. Non-allergic rhinitis in 23%. And mixed rhinitis, allergic and non-allergic, in 34% of our patients. Next, we talk about classification of rhinitis. And first, we talk about etiological classification of rhinitis. All group of rhinitis we divided into IgE-mediated or allergic rhinitis, autonomic rhinitis, infectious rhinitis, and idiopathic rhinitis. And on our lecture, we'll talk about, first of all, IgE-mediated rhinitis. In this rhinitis, we see IgE-mediated inflammation of the nasal mucosa, and you see that this is a result of eosinophilic inflammation and T helper 2 cell infiltration of nasal lining. Autonomic rhinitis. To this group of rhinitis belong vasomotor rhinitis, drug-induced rhinitis, sometimes medication may lead to development of this rhinitis. Also rhinitis due to hyperthyroidism, hormonal rhinitis, and non-allergic rhinitis with eosinophilia syndrome. In this case, we see eosinophilia in nasal in this group of patients, but we don't see development IgE-mediated inflammation. Infectious rhinitis. Sometimes very easy to differentiate infectious and allergic rhinitis. It may be bacterial rhinitis, fungal rhinitis, but more often, most common we see patients with viral rhinitis. And group patient with idiopathic rhinitis when etiology cannot be determined. Also, we see this group of patients. Which phenotype of rhinitis more common we see in our practice? First of all, it's allergic rhinitis and infection rhinitis, acute viral rhinitis or fungal. Also, such group of rhinitis as non-allergic rhinitis with eosinophilia, and chronic rhinosinusitis with or without polyps. Less common, we see such phenotypes rhinitis as drug-induced. First of all, it may be aspirin-induced rhinitis. Some vasodilators also lead to drug-induced rhinitis. Next group of patients is hormonal rhinitis during pregnancy, menstruation, after using contraceptives or thyroid disorders. Sometimes, rare, we see food-induced rhinitis. In some group of patients, cold air-induced rhinitis also may be. In elderly person, we see atrophic rhinitis. Also, symptoms may be similar to other type of rhinitis. And when we talk about this group of patients, very important to talk about effect of rhinitis on quality of life, because 62% of patients with allergic rhinitis are bothered a great deal while symptomatic, report difficulty sleeping and increased daytime fatigue, have decreased levels of cognitive function, and some other function that bothering quality of life. And now we talk about patient with allergic rhinitis. More often we see allergic rhinitis at younger age. Symptoms may be during season or all year round, and is dependent of sensitization or which allergen lead to development this type of rhinitis. Which symptoms of allergic rhinitis more often we see in our patient? First of all, congestion, rhinorrhea, nasal itch, and sneezing. And on this picture you see a boy with nasal salute. What risk factors may activate allergic rhinitis? First of all, when we talk about risk factors for allergic rhinitis, we talk about genetic susceptibility. When we ask about family history of atopy, we see that we have asthma, eczema, high fever, and urticaria in family history. Brother or sister of our patient, mother or father usually have this group of disease. And also we know genes that involved in atopy. Usually it's genes lots on 5q, 11q or 12q chromosomes. Some environmental factors lead to activation allergic rhinitis. It may be pollution, climate interaction, also very important when we talk about activation subgroup of allergens. Irritation. Some irritants may activate symptoms of allergic rhinitis. First of all, we must talk about tobacco smoke. Active and passive smoke, very important when we talk about our patient with allergic disease, with allergic rhinitis and bronchial asthma. Mosquito repellents, perfumes, domestic sprays, leeches, and some other irritants can provoke symptoms of rhinitis. And also exposure to allergens. It may be seasonal allergens and perennial allergens. And what source of allergens? Very important when we talk about development of allergic rhinitis. You can see on this picture house dust mites, and you see domestic mites. Next group of allergen is the pollen, grass, tree and wheat pollen. Pets, first of all we talk about cat and dogs. Cockroaches in some areas also important, and mold. And all these allergens we can divide it into two groups. Seasonal, it's tree pollen, grass pollen, mold pollen. In some region wheat pollen. In our region wheat pollen it's perennial, leads to development perennial symptoms. And you see perennial triggers of allergic rhinitis. It's dust mites, cockroaches, pets, mouse, and wheat pollen, sometimes mold spores. And when we talk about triggers of allergic rhinitis, also we must talk about occupational rhinitis. Occupational rhinitis is less well documented than occupational asthma, but nasal and bronchial symptoms often coexist in the same patient. So very important to ask our patient about occupation, because that also may trigger symptoms of rhinitis. Next group of triggers is latex allergy. Latex allergy has become an increasing concept to patient and health professional, especially for doctors, because latex allergy is our professional allergen. And health professionals should be aware of this problem and develop strategies for treatment and prevention. Indoor air pollution. is of great importance since subjects in industrialized countries spend over 80% of their time indoors. And as we talk, indoor pollution include domestic allergens and indoor gas pollutants, among which tobacco smoke. And in many countries, urban type pollution is primary automobile origin, and the principal atmospheric pollutants include ozone, oxide of nitrogen, and sulfur dioxide. When we talk about different type of drug, first of all, we must talk about aspirin as triggers of allergic rhinitis and bronchial asthma. Aspirin and other non-steroidal anti-inflammatory drugs may induce symptoms of rhinitis and sometimes activate symptoms of bronchial asthma. And next, very important factors about allergic rhinitis. This is genome-wide association. We know about 41 loci that associated with allergic rhinitis. And function of this gene involved in regulation of B cell and T cell, and we'll talk about T helper 2 cell that activate B lymphocyte produce immunoglobulin E, and also these genes associated with allergic rhinitis, and genes that involved in antigen recognition. Most strong signal from HLA-DQB1, and all these genes overlap with asthma, eczema, autoimmune disease, and also non-allergic rhinitis. Now talk about pathophysiology of development allergic rhinitis. We have different very important stage of development allergic rhinitis. First, it's sensitization, development of specific immunoglobulin E. And as we see on the next picture, first we see allergen-rich antigen-presenting cell. Antigen-presenting cell promote T helper 2 polarization. T helper 2 activate production of specific immunoglobulin E. And after this, we see a subsequent response or development of symptoms. First of all, we'll talk about nasal symptoms, and these symptoms we divided into two groups: early phase symptoms and late phase symptoms or late phase response. And when we talk about symptoms, also we'll talk about specific hyperresponsiveness and non-specific hyperresponsiveness. And also we must remember about lower airway symptoms, because asthma very often may be in patients with allergic rhinitis. And on this picture we can see sensitization patient with development allergic rhinitis. First of all, you can see allergen. This allergen recognized by antigen-presenting cells or dendritic cell. Antigen-presenting cell present this antigen in the complex with MHC class 2, and this complex MHC class 2 and antigen recognized by T helper lymphocyte. And also we see production such interleukins as interleukin 4, interleukin 5, and interleukin 13. This interleukin act on T helper, and our T helper become T helper 2. After this, you can see this is T helper 2. T helper 2 activate humoral immune response, and we see activation of B cell. On this picture, you see interaction between T lymphocyte and B lymphocyte, and you can see interaction between receptor of the T cell and the B cell, CD40 ligand and CD40 receptor. T lymphocyte also produce interleukin 4, 5, and 13, And we see activation T lymphocyte, B lymphocyte. B lymphocyte become plasma cell, and B lymphocyte produce immunoglobulin. First immunoglobulin that produce B lymphocyte, immunoglobulin M, and after activation this cell by T helper 2, we see switch on production to immunoglobulin E. Immunoglobulin E is specific immunoglobulin E to antigen or allergen that lead to development with sensitization. After this, we see production of immunoglobulin E by B lymphocyte. Immunoglobulin E bind to mast cells and basophils, and after re-exposure of antigen, we see production different type of mediators from this cell and development of allergic response. And on this picture, we can see mast cell, mediators in the granules of mast cell. You can see leukotrienes, prostaglandins, and histamine. It's very important mediators of mast cell. And also we can see immunoglobulin E on the surface of mast cell. And after these two immunoglobulin E bind with allergen, we see degranulation of mast cell and releasing mediators from mast cell. And now we talk about very important inflammatory mediators that released mast cell eosinophils and lymphocyte. First of all, you know, it's histamine. Histamine leads to development itching and rhinorrhea in patients with allergic rhinitis. Leukotrienes. Function of leukotrienes, it's hypersecretion of mucus, edema, due to increase in vascular permeability, and other type of cytokines also released from these inflammatory cells, include interleukins 4, interleukin 3, and interleukin 5. Interleukin 4 also very important because interleukin 4 stimulate IgE production, immunoglobulin E production. Interleukin 3 and 5, very important in activation eosinophils and mast cell recruitment. So we see reactivation of this inflammatory immune response. And on this picture, you can see two phases of immune response, allergic immune response, early phase and late phase. We see mast cell on this picture, mast cell, and we see degranulation of mast cell. We see immunoglobulin E that bind with mast cell, antigen, it may be pollen, mites, rat's hair, and other. And after active binding with immunoglobulin E on the surface of mast cell, we see degranulation of mast cell. And we talk that mast cell produce histamine. Histamine activates through histamine receptor different types of symptoms. Leukotrienes. Leukotrienes bind with leukotriene receptor, and we see some other symptoms of allergic reaction. It's early phase of allergic reaction. Late phase of allergic reaction due to other type of cells, basophils first of all, and eosinophils. Eosinophils produce ketonic protein, and this is very important protein, and we will talk about this protein on other next lecture. And immediate hypersensitivity reaction, you can see these mediators that we talk about, the histamine, leukotrienes, prostaglandin, chemins, and symptoms that lead to these mediators: itching, sneezing, and congestion. Late phase reaction. In late phase reaction, we see prolonged nasal symptoms after allergen exposure. And mediators that we see in late phase reaction, first of all, it's cytokines and chemokines. And these mediators lead to activation inflammatory cells. Inflammatory cells release further inflammatory mediators, which can worsen nasal symptoms and prime the nasal mucosa. And a very important concept when we talk about allergic disease, not only allergic rhinitis, also about allergic asthma and eczema, it's a concept of minimal persistent inflammation. This is very important. Even through symptoms-free in our patient with persistent allergic rhinitis, also asthma and eczema, presence with inflammatory, in this case of the nose. And on this picture, you can see what this concept of minimal inflammation. On this part of picture, we see visible symptoms. It's maybe runny nose, sneezing, itchy nose. Also, in patients with allergic rhinitis, we see symptoms such as watery eyes, itchy eyes. Also, in some group of patients, we see chronic nasal congestion and sometimes maybe exacerbation of asthma symptoms. And on this part of picture, you see underlying inflammation. And due to this underlying inflammation, we see development hyperreactivity of tissue, hyperactivity. And this is concept minimal persistent inflammation because we see only visible symptoms, and underlying inflammation we see as symptoms of hyperactivity. And now talk about classification of allergic rhinitis. All patients we divided into two groups: patients with intermittent rhinitis and persistent rhinitis. This is divided due to duration of symptoms. If we see symptoms less than 4 days per week or less than 4 weeks, we talk about with intermittent rhinitis. If we see symptoms more than 4 days per week and more than 4 weeks, we see patient with persistent rhinitis. And very important when we talk about our patient, mild or moderate or severe inflammation, severe symptoms we see in our patient. Patient with intermittent rhinitis may be mild or moderate, and with persistent rhinitis also may be mild or moderate. What's the difference between these conditions? Mild symptoms, when we see normal sleep in our patient, don't see impairment on daily activities, sport and leisure. It's very important because we talk that our patient more often it's a young patient. Normal work and school, and no troublesome symptoms. In which case we talk about moderate or severe symptoms, when we see one or more items: abnormal sleep, impairment on daily activities, sport or leisure, abnormal work and school, and troublesome symptoms. If we see one of these items or more, we talk about moderate allergic rhinitis. And so, also very important when we talk about allergic rhinitis, and when we see patients with allergic rhinitis, we must remember about comorbidities of allergic rhinitis with other allergic and non-allergic disease. First of all, it may be upper respiratory infection. And very important, think about bronchial asthma in this group of patients. Very often we see in patients with allergic rhinitis, allergic sinusitis. Also, it may be otitis media in patients with allergic rhinitis. And also very often we see in our patient nasal polyposis. And now talk about symptoms, clinical symptoms of allergic rhinitis. First, we talk about nasal symptoms, and you remember we talk about this. Its nasal symptoms include nasal itching, sneezing, rhinorrhea, and nasal obstruction. hypasmia. And more often in our patient also we see ocular symptoms. It may be eye itching, red eyes, and swollen eyes. If we see the symptoms, also we must treat and diagnose in our patient allergic conjunctivitis. Which are the clinical symptoms you can see in patient with allergic rhinitis? It's oral allergy symptoms. First of all, we see this group of symptoms when we see allergic reaction to different type of pollen, because you remember pollen may give cross-reactivity with food allergy. So we can see oral allergy symptoms. We see oral or pharyngeal itch and rare angioedema of lips, mucus, soft palate, and pharynx may be in this group of patients. And also in patients with allergic rhinitis, we can see other symptoms, sleep disorders and emotion problem. Symptoms can also extend to ear, sinuses, and lungs. And when we talk about severity of disease in our patient, now we can use visual analog scale. It's very easy. And you can see the scale in this picture. This scale are psychometric measuring instrument designed to document the characteristics of disease-related symptom severity in individual patient and use these to achieve a classification of symptom severities. Also, we use this to prescribe different type of treatment, and also we use this scale to control treatment and to control disease. So you can see visual analog scale, mild symptoms when scale from 1 to 3, moderate symptoms from 3 to 7, and severe symptoms if our patient talks about that severity 8 or more. And now we talk about diagnosis of allergic rhinitis. Diagnosis of allergic rhinitis begins with history. After this, we use examination. Next, diagnosis that includes skin test and radioallergic sorbent test for specific immunoglobulin E. It's part of very important diagnosis steps. First, we talk about anamnesis. Which important element in history we must ask our patient? First, its nature, duration, and time course of symptoms. And you remember, if we see patient with seasonal symptoms, for example, in April and May, we think that this is allergic reaction to tree pollen. If we see symptoms during all year, it may be domestic pet allergic reaction or dust mites allergy, or it may be mold allergy when we talk about indoor mold. If we see patient with outdoor mold, we see symptoms during autumn and spring. Also very important to ask about possible triggers for symptoms. It may be cold air, it may be tobacco smoke, some perfumes, and some others. Also very important for us, response to medication. With medication, our patient used to improve symptoms. Comorbid condition, it may be sinusitis, otitis, conjunctivitis, or bronchial asthma. Also very important, family history of allergic disease. We ask about which disease our patient have in family. It may be bronchial asthma of mother our patient, or eczema in other family member, or some others. Also ask about environmental exposures, occupational exposures, and Also, I think it's very important effect on quality of life. And on this picture, you see the most easy question for patient with allergic rhinitis. Does the patient have the symptoms associated with allergic rhinitis? Are these seasonal or perennial or both? Does the patient have concurrent allergic conjunctivitis, asthma, atopic dermatitis, etc.? And now talk about symptoms that can be associated with allergic rhinitis. It may be sneezing, itching, rhinorrhea, postnasal drip, also very important symptoms, congestion, headache, earache, tearing, red eyes, fatigue, drowsiness, and malaise. Next part of examination is a physical examination. And during physical examination, you can see variable appearance of mucosa. It may be mucosal pallor, edema, hyperemia, allergic shyness, dark discoloration of the periorbital skin. Denny Morgan lines, it's a unfold of the lower eyelid in children. Allergic crease, horizontal wings near the tip of the nose, and you can see this in picture, nasal crease. And also absence of foreign body, tumor, and purulence we must diagnose it during physical examination. And next we use diagnostic test because we think about IgE, allergic reaction, in our patient. All diagnostic tests, usually we divide it into two groups. It's skin test and blood test. Skin test, it's very easy test. Also, we see specific monoglobulin E in skin. On this picture, you can see positive skin test in patient with allergic reaction. Allergen introduced into skin, and after this we see degranulation of IgA sensitized mast cell in skin, and mast cell produce different type of mediators, first of all histamine, and production of histamine lead to formation wheals and flare. This test very simple with result after 20 minutes. It's very cheap and safe test for diagnosis of allergic reaction. In this test, a low risk of systemic reaction. And also you must remember about positive and negative control when we use this group of tests. Advantages of this test: it's cheap, immediate result after some minutes, and sensitive. Contraindication: patient with using antihistamines or hormones, severe eczema, severe bronchial asthma, previous anaphylaxis, and dermographism. Sometimes we can use prick-prick test. We use this test for diagnosis food allergy. For food allergy testing, to a wide variety of foods, such as nuts, fish, shellfish, meat, fruits, wheats, and yeast, this test may be available. Individuals with allergy to less common foods and complex sauce can be tested by technique that we call prick-to-prick testing, where the actual potential food allergen is lightly pricked into the skin. Also, we see result after 20 minutes. This test result very similar to skin prick test, and indication and contraindication also similar. Next group of tests that we use for diagnosis of allergy, it's a blood test. Total IgE test. Rare, we use for diagnosis allergic rhinitis because usually we see normal IgE levels in blood, total IgE levels in blood in patients with allergic rhinitis. So we use specific monoglobulin E test. We use RAST test or radioallergy sorbent test. In this test, you can see allergen and patient IgE. Stabilized allergen incubated with patient serum. Any specific IgE bind to allergen, and you see that only allergen-specific IgE bind to this allergen. After this complex labeled with anti-IgE antibody, and after this we can identify it by a second incubation with labeled anti-E this complex using radio labeling. And next test that we can also use, additional test for diagnosis of allergic rhinitis, it's a nasal endoscopy. Also we can use nasal secretion for cytology, nasal challenge test with allergen. Sometimes we can use rhinomanometry and CT scan test. Nasal allergen challenge test. In this test, allergen is introduced into the nose and any reaction is measured and compared to placebo. Nasal allergen challenge is the gold standard of allergy diagnosis, but we rarely use this test. The allergen should be applied in gradually increasing concentration with careful monitoring. Sometimes it's very difficult to do. Nasal challenge test is time-consumed, difficult, and require extensive laboratory facilities. On this picture, you can see nasal endoscopy in patients with allergic rhinitis, and you can see that we see polyps in this patient with allergic rhinitis. On this picture, you see rhinomanometry result test. We use inspiration and expiration maneuver, and on this picture you see normal test, normal graphic, and obstruction, nasal obstruction. And now we talk about differential diagnosis, allergic rhinitis, and other type of rhinitis. First of all, we'll talk about vasomotor rhinitis, because very often we see this group of patients with vasomotor rhinitis. Next, we'll talk about such group of patients that have very similar symptoms to allergic rhinitis, sinonasal polyposis, and rhinitis medicamentosa. Also, sometimes we see, especially such group of our patients that use intranasal decongestant, patient with hormonal rhinitis, and some others. When we talk about allergic and non-allergic rhinitis, patient with allergic rhinitis, usually we see present symptoms in childhood, and patient with non-allergic rhinitis, usually symptoms we see developed after the age of 20. In allergic rhinitis, we see strong family history of atopic disease. It may be bronchial asthma, atopic dermatitis, or some other disease. In patient with non-allergic rhinitis, there is no evidence of family history of allergy. In patient with allergic rhinitis, maybe this group of patients may be sensitized to only perennial allergens such as cat or dust mite. Most are sensitized to seasonal pollens and thus have seasonal symptoms. Patient with non-allergic rhinitis almost always complain of perennial symptoms. When we talk about triggers factors, for allergic rhinitis, triggers factors are allergens. For non-allergic rhinitis, triggers is broad. It includes strong smells, irritants, changes in weather, hot weather or cold weather may lead to uh, symptoms of non-allergic rhinitis, barometric pressure, hormonal fluctuation, and ingestion of food or alcohol. Patients with allergic rhinitis have very significant sneezing and nasal itch. Patients with non-allergic rhinitis typically complain of nasal congestion and rare have significant pruritus or sneezing. Most allergic patients also have troublesome ocular symptoms with conjunctivitis, injection, tearing, and itch. And in patients with non-allergic rhinitis, usually we don't see this group of symptoms. When we see a patient with allergic rhinitis, nasal mucosa in allergic rhinitis is edematous, body and often with blue-white hue. Nasal examination in non-allergic rhinitis is more variable and dependent on the underlying cause of disorders. Nasal mucosa may appear essentially normal with increased clear watery secretion or may be erythematous or even atrophic. And now we talk about management of allergic rhinitis. When we talk about allergic rhinitis, very modern recommendation, it's a step-wise management. And on this picture, you see 3 steps that we use in patients with allergic rhinitis. Step 1, it's allergen avoidance and environmental control, very important. It's a recommendation for all patients with allergic rhinitis. Step 2, it's pharmacotherapy. And step 3, it's immunotherapy, especially if pharmacotherapy not effective. And remember some recommendation for our patient about avoidance of different type of allergen. On this picture, you can see house dust mites and which recommendation we give our patient with allergic reaction to house dust mites. You see, this include provide adequate ventilation to decrease humidity, wash bedding regularly at 60 degrees, encase pillow mattresses and quilt in allergen impermeable covers. Use vacuum cleaner with HEPA filter when available. Dispose of further bedding. Replace carpets with linoleum or wooden floors. Remove curtains, beds, and stuffed toy from bedroom. It's very easy recommendation, but very effective. When you see patient with pollen allergy, when we talk about pollen, you understand that this allergen very difficult to avoid, but we must give our patient recommendation to avoid some pollen. And this recommendation includes remain indoor with windows closed at peak pollen times, usually it's morning times, wear sunglasses, use air conditioning where possible, install car pollen filter. If you see pet allergens that lead to development symptoms in patient, you recommend exclude pets from bedroom and where possible from home, but sometimes it's not possible for our patient. Also, we recommended wash pets regularly and use vacuum carpets, mattresses and upholstery regularly. Cockroach allergens also may lead to development allergic rhinitis. And very important in this case, eradicate cockroaches with appropriate insecticide. Eliminate dampness, cracks in floors, ceilings, cover food, wash surfaces, floor, fabrics to remove this allergen. And also such allergen as mold. Very often we see this group of patient. And if we see mold in home, it may lead to development perennial symptoms, out of home, maybe seasonal symptoms. But which recommendation we give our patient? Ensure dry housing, use ammonia to remove mold from bathroom and other wet spaces. And also, when we talk about allergic rhinitis, our patient can use new technology to avoid allergens. On this picture, you see the allergy advisor that contain weather and pollen forecast in area of your patient. Also on this site, you can see triggers and symptoms logs for multiply location. And also, it may contain healthcare professional contact. Sometimes it's very useful for our patient. Which general advice also we can give our patient? First of all, it's avoid irritants. You remember, I must recommend to avoid smoke, dust, and other atmospheric pollutants. Physical factors. Also remember that some physical factors, for example, extreme changes in temperature, can produce symptoms in non-IG mediated response patient, and in patient with allergic rhinitis also it may increase symptoms. Also, we can recommend to avoid these extreme changes in temperature. Also, it's helpful avoid food and drugs to which our patient allergic. And also, I recommended avoid occupational irritants or change professions if it's possible. Next group of recommendation, next group of treatment include patient education. Educate patient on environmental control measures which involve both the avoidance of known allergens and avoidance of non-specific factors, irritants and triggers. Next recommendation for our patient is using nasal douche. On this picture, you can see how our patient must use nasal douche. And you see wrong using of nasal douche on this picture. And also what recommended for our patient, how they may use nasal douche. And you see this recommendation that include shake bottle well, look down, using right hand for left nostril, put nozzle just inside nose, aiming towards outside wall. Squeeze once or twice, two different directions you see also on this picture. Change hand and repeat for other side. Do not sniff hard. And also you see it's maybe different model for use nasal douche. Also, for our patient, maybe recommended respirators or filter nose, nasal mask. And you can see on this picture some of example nasal mask. This nasal mask recommended for adults with condensation nose. This nose mask may be different diameter, and we recommended use this mask for protection from pollen, dust, household and building, animal hair, fungal spores, bacteria, aerosols, smoke, fumes, and others. And this mask don't recommend to use at a cold and nasal congestion. Sometimes it may be very useful for our patient. And on this picture, you can see area allergic rhinitis and impact on asthma guidelines for the treatment of patient with allergic rhinitis. And you can see treatment divided in different group of patients. First, you see patient with intermittent mild rhinitis, intermittent mild, moderate or severe rhinitis, and persistent mild and persistent moderate and severe rhinitis. Which group of medication include treatment? First of all, it's you see oral and local non-sedative H1 blockers, intranasal corticosteroids, also you see cramons, intranasal decongestant or oral decongestant. Also, we talk about this allergen avoidance, and in patients with persistent rhinitis, we recommended use immunotherapy. And on this picture, you can see six very important group of drugs that we use in patients with allergic rhinitis. You see antihistamines that we divided into topical and systemic. Topical, it's azelastine. Systemic, you see cetirizine, levocetirizine, fexofenadine, loratadine, and desloratadine. Nasal decongestant, also may be topical and systemic. Mast cell stabilizers, or cramons, anticholinergic drugs, ipratropium bromide, nasal spray, corticosteroids. We recommend to use topical corticosteroid, different type you can see, and very rare in severe exacerbation, we can use systemic corticosteroids in a short period of time. And next group, leukotriene receptor antagonist. More often we use montelukast. On this picture, you can see this group of drugs that we use and what effect this drug may have on different symptoms. And as we see, oral antihistamines, very good effect on itching, sneezing, and also discharge, and some effect on nasal blockage. Topical corticosteroids, good effect on all symptoms of allergic rhinitis. Systemic corticosteroids also very good effect, but you know that systemic corticosteroids very often have severe side effect. Antileukotrienes, group that can lead on nasal blockage and impairment smell, also very important for our patient. Ipratropium bromide, only effect on discharge. And cramons, group of cramons, very small effect on all symptoms we see. And first group of medication, we talk about oral antihistamines. When we talk about oral antihistamines, you know that we have two generations of oral antihistamines, first generation and a newer generation. And you can see different example on this slide, first and second generation antihistamines. First, we talk about first generation oral antihistamines. You can see first generation include chlorpheniramine, diphenhydramine, promethazine, and some others. And we reuse this generation for treatment patient with allergic rhinitis, use limited by sedative and anticholinergic effects. And also we must remember about tachyphylaxis effect, first generation of oral antihistamine. Topical antihistamines that we can use, azelastine and levocabastine. This is a very important group of antihistamines, and now we use these topical antihistamines in combination with intranasal corticosteroids, and this is a very effective combination. You can see that azelastine have rapid onset of action, 15 minutes. It's very important for our patient. This drug we use twice daily.
We may use this continuously, and also, as last time, and levocabastine useful in non-allergic rhinitis and have good safety profile. And when we talk about antihistamines, very important to talk about ideal new generation oral antihistamines. This group of drugs have no sedation, use once daily, rapid onset, about 10 to 20 minutes, and duration 24 hours, duration of action, no interaction with other drugs, food, and alcohol, and additional anti-allergic effect also we can see in this group of drugs. And on this picture, you see example of new generation oral antihistamines. And this drug first-line treatment for intermittent and mild persistent allergic rhinitis. So that when we see patient with allergic rhinitis, we begin treatment with this group of drug, new generation of oral antihistamines. On which symptoms affect this second generation antihistamines? Reduce sneezing, itching, runny nose, some effect on congestion, and generally preferred by patient because very easy use these drugs one time per day. And on this picture, you can see mechanism of action of antihistamine drug. You see, first of all, this is histamine receptor, H1 histamine receptor. We can see the structure of histamine receptor, and you see 5 proteins that contain this receptor. And this histamine receptor have 2 conformation states. It may be inactive on picture A and active when we see development of symptoms. Histamines act as agonist to activate the H1 histamine receptor. We can see on this picture histamine bind with 3 and 5 protein in histamine receptor, and we see activation of histamine receptor. Antihistamines on this picture act as inverse agonist to inactivate H1 histamine receptor. The H1 histamine receptor surface is connected to the 3 and 5 transmembrane domain to activate, you see on this picture, and this effect of histamine. And if we see activation 4th and 6th transmembrane domain, we see inactivation of histamine receptor. So, we must remember that newer generation oral antihistamine is a first-line treatment for mild allergic rhinitis. Effective on symptoms rhinorrhea, nasal pruritus, and sneezing, and less effective for nasal blockage. Sometimes in some medication of this group have additional anti-allergic and anti-inflammatory effect. We don't see sedative effect when we use this group of oral antihistamines. Very important that these drugs one daily administration. And also this drug have rapid onset and 24 hours duration of action. It's very important for our patient. Next group, very important drug, is topical corticosteroids. And you see on this picture examples of topical corticosteroids. You see that this includes beclomethasone, budesonide, flunizolide, fluticasone, mometazone, and some other drug. When we talk about corticosteroids, we must remember about effect that have corticosteroids. And we divided two mechanism of action corticosteroids, genomic effect and non-genomic effect. And on this picture, you can see blood vessel. And first, we see that steroids bound to plasma protein and only unbound hormones can diffuse into target cells. After this, you see steroids in cells, steroid hormone receptor in cytoplasmic or nucleus. We see cytoplasmic receptor and you see steroid hormone bind with this receptor. The receptor hormone complex bind to DNA and activate or repress one or more genes. It's very important when we talk about genomic effect of corticosteroid. Activated genes create new RNA that move back to the cytoplasm, and translation produce new proteins to cell process. And usually we see that this protein have anti-inflammatory effect. Some steroids hormones bind to membrane receptor. You can see on this part of picture that use second message system to create rapid cellular response. And this is non-genomic effect of corticosteroids. Non-genomic effect of corticosteroids. So, when we talk about pharmacologically of corticosteroids, we see two mechanisms. When corticosteroids bind with the receptor in the cytosol, we see activation, genomic effect, genomic action. It's slow process, and we need some hours or some days to see effect after this genomic action. And what we see? Expression of proteins lead to activation anti-inflammatory effect. And repression of some proteins lead to pro-inflammatory effect. On this picture, we see non-genomic effect of glucocorticosteroids. When we talk about non-genomic effect, you can see that corticosteroids bind with corticosteroid receptor on membrane of cell. After this, we see that calcium, AMP, alter, and their downstream kinase, and rapidly expect anti-inflammatory effect and shut down pro-inflammatory effect. Its rapid process needs minutes and sometimes hours. And what's the difference between genomic and non-genomic effect? First, it's receptor location in genomic effect in cytoplasm and non-genomic effect on membrane of cell. Onset in genomic effect slow and rapid in non-genomic effect. Action. In genomic effect, regulation of inflammatory gene transcription, and we see such effect. Decrease hyperperfusion, hyperpermeability, leukocyte recruitment, and angiogenesis. When we talk about non-genomic effect, action, inhibition of local gate telomerase disposal, and we see increase hyperperfusion. It's very rapid effect, usually develop very quickly. And on this picture also we can see very important effect of nasal corticosteroids. First, it's reduction of mucosal inflammation, and this lead to reduction of late phase reaction, primary nasal hyperresponsiveness. Second effect, reduction of mucosal mast cells that lead to reduction of acute allergic reaction. And the next effect, suppression of glandular activity and vascular leakage, and induction of vasoconstriction. All of this lead to reduction of symptoms and exacerbation. So when we talk about nasal corticosteroids, first of all, when we talk about this group of drug, we talk about anti-inflammatory effect as a result of action nasal corticosteroid. This drug very effective in treatment of all nasal symptoms, and this drug more effective than antihistamine and anti-leukotrienes. When we see patient with persistent allergic rhinitis, nasal corticosteroids, it's a first-line pharmacotherapy. Next group of drugs that we sometimes use in patients with allergic rhinitis is systemic corticosteroids. Systemic corticosteroids usually we use in short course, less than 5 days, usually 3 days, in patients with severe refractory symptoms. Sometimes we see osteoporosis after using these drugs and some other side effect. And intramuscular injection should be avoided when we use systemic corticosteroids. Next group of treatment, anti-allergic treatment or hormones. We can use chromoglycate and nedecramine. This drug less effective than antihistamine. Require frequent administration. We use this drug 4 times per day and nedecramine 2 times per day. But this group of drugs have excellent safety profile, and this is especially important in children and pregnancy patients. Next group of drug, anticholinergic drug, ipratropium bromide, effective in controlling watery nasal discharge, but not sneezing or obstruction. Unwanted effect may include nasal dryness, irritation, and burning. And also, drug that very often use our patient is decongestant. Decongestant may be oral and nasal. Oral decongestant, pseudoephedrine, and nasal decongestant, phenylephrine, oxymetazoline, and xylometazoline. When we use oral tablets, this is less effective than sprays, but these tablets not lead to development medicamentous rhinitis. Sometimes we can combine these tablets with oral antihistamine, and we avoid this group of drug in children less than 1 year, in pregnancy person with hypertension, cardiopathy, prostatitis, and glaucoma. Topical spray, very effective in treating nasal obstruction, but limit treatment. We can use this drug only 3 to 10 days, because after these days we can see development medicamentous rhinitis. And this group of patients very difficult to treat because they have allergic rhinitis and also medicamentous rhinitis. Next group of drug, anti-leukotriene agent. In our country, we can use montelukast. Efficacy. This group of drug can reduce nasal and systemic eosinophilia. And more often, we use this drug in patients with comorbid allergic rhinitis and bronchial asthma, because this drug may affect on symptoms, rhinitis symptoms and asthma symptoms. Sometimes we can see development dyspepsia in this group of patients. Leukotrienes, anti-leukotrienes less effective than inhaled corticosteroid and antihistamines, may have additive effect with antihistamines, efficacy in aspirin-induced rhinitis and asthma, because we must talk about, remember, mechanism of aspirin-induced allergic reaction. And this drug expensive, so sometimes we can't use this drug. And this was pharmacological treatment for patients with rhinitis. And next step of treatment include immunotherapy. What is immunotherapy? This is repeated administration of allergen extract in order to induce immunological tolerance, with reduction in clinical symptoms and requirement for medication during subsequent natural allergen exposure. Immunotherapy indicated in those patients of allergic rhinitis who failed to respond adequately to usual treatment with antihistamines and topical corticosteroids. In view of side effects associated with subcutaneous immunotherapy, alternative strategies have been considered. So more often we use sublingual immunotherapy. Sublingual route involved application of allergens as drops or tablets under the tongue, where they are retained for several minutes. It's very easy for our patient, and this type of immunotherapy our patient may use at home. What mechanism of immunotherapy? Immunotherapy results in blunting of seasonal increase in allergen-specific immunoglobulin E. Immunotherapy induces immune deviation from T helper 2 type T lymphocyte response in favor of a protective T helper 1 type response, and also to induce a distinct population of T regulatory cells, which produce the inhibitory cytokines interleukin 10, tumor growth factor beta, both of which downregulate T helper 2 responses to allergens. And on this picture, we can see dendritic cell present antigen, and we see activation T helper lymphocyte. After using immunotherapy, we see decreased T helper 2, increased T helper 1, and also increased T regulatory lymphocyte. In immune system, we see these changes. And a very modern drug for treatment allergic rhinitis, it's human monoclonal antibodies or anti-IgE drug. And for patients with allergic rhinitis, recommended omalizumab. It's the first of several monoclonal antibodies that we use in patients with bronchial asthma, and also we can use omalizumab in patients with allergic rhinitis. This drug effect are modulation of allergic inflammation. And this drug expensive for routine treatment of allergic rhinitis. But when we see patients with severe allergic rhinitis and severe bronchial asthma, we can use this group of drug. When we treat our patient with allergic rhinitis, we must evaluate symptoms of allergic rhinitis. And to help our patient to see the changes in symptoms, we can use total nasal symptom score. And in this score, we see intensity of nasal symptoms in different period of treatment, before treatment, during treatment, and after treatment, which symptoms we see: rhinorrhea, nasal itching, nasal obstruction, and sneezing. Which score? Maybe 0, it's no symptoms, 1, mild symptoms of rhinitis, 2, moderate symptoms, and 3, severe symptoms of rhinitis. And total possible score ranges from 0, no symptoms, to 12, maximum symptoms intensity. And very important for our patient, use this score during treatment, so we can see effect of treatment, or we don't see effect, and we must change our treatment to see good effect in our patient. And on this picture you can see mask allergy diary. This is a diary to patient with allergic rhinitis. This program free for our patient, and you can see that this program includes visual analog score for our patient. Also, we see our patient can write symptoms, intensity of symptoms, and also which drug our patient uses. When we talk about treatment of our patient, first of all, very important, talk with our patient about intensity of symptoms of allergic rhinitis. And you remember we use visual analog score. And when we see that visual analog score less than 5 or 50, we use oral H1 blockers or intranasal corticosteroid. The oral H1 blockers we prefer in this group of patients. If we see VAC more than 50, first drug that we use intranasal corticosteroids, or also we can use oral H1 blockers. After this, we must review symptoms after 5 to 10 days, and our next step will depend from intensity of symptoms. If we see symptoms less than 20, we continue treatment if it needed. From 20 to 50, also we continue treatment, and if we see score more than 50, we use step up if possible. More often we use combination intranasal corticosteroids and intranasal H1 blockers, or we can use some other drug, anti-leukotrienes, the congistant, short course of systemic corticosteroid, and some other drug for treatment of our patient. On this picture, also you can see step up therapy and step down therapy, how we use our choice. First, you can see that recommended use antihistamines, oral and intranasal. If we see poor control in our patient, we change this treatment for nasal corticosteroids. Also, if we see poor control, we use step-up therapy. And you can see additional, we can use antihistamines, very effective intranasal antihistamines, azolastine, or leukotriene receptor antagonist to nasal corticosteroids, and we use this of treatment. Also, you see recommended avoid triggers and saline douche. In well-controlled patient, we can use step-down therapy. We can use only nasal corticosteroid, or in well-controlled patient, only antihistamine, oral or nasal. In patient, when we use combination antihistamine, intranasal corticosteroids, leukotriene antagonist, and we don't see a good effect, we can see use specific immunotherapy. And now we talk about combined allergic rhinitis and asthma syndrome, because very often we see this group of patients. Allergic rhinitis and allergic asthma frequently coexist. These separate disorders are manifestation on the same disease expression to a greater or lesser extent in either the upper and the lower airway. This concept has important implication for both the diagnosis and the treatment of these extremely common and potentially desirable illnesses. Asthma and rhinitis are common comorbidities, suggesting the concept of one airway, one disease. And on this picture, you see clinical recommendation of World Health Organization, allergic rhinitis and its impact on asthma. And you see this guide. It's maybe different guide for doctors, for pharmacists, and some nurses recommendation for patients with allergic rhinitis, how we treat this group of patients. When we talk about prevalence of asthma and rhinitis, you can see on this picture. In Sweden, we see asthma, 8% rhinitis, 15%. In Kenya, asthma, 8%, rhinitis, 13%. Brazil, asthma, 10%, rhinitis, 22%, and very similar in other countries. When we talk about rhinitis, we talk that rhinitis, allergic rhinitis, occurs usually in 20 to 30% of general population and occur in greater than 80% of asthmatics. Asthma occur around 5 to 15% of general population and occur in up to 40% of allergic rhinitis patients. And on this picture, you see group of patients with asthma and a group of patients with allergic rhinitis. And this group of patients have allergic rhinitis and bronchial asthma. And when we talk about epidemiologic, we see that we see a link between rhinitis and asthma. Up to 80% of all asthmatic patients have allergic rhinitis, and this is very good picture. This group of patients with asthma, and green is patient with asthma and allergic rhinitis. And also very important pathophysiological link between allergic rhinitis and asthma that contain common triggers for development of this disease, common functional interaction, similar inflammatory cascade on exposure to allergen. Cysteine leukotrienes are common mediators in upper and lower airway disease. Similar pattern of early and late phase responses, infiltration by the same inflammatory cells, and we will see these cells as eosinophils, for example, several potential connection pathways, including systemic transmission of inflammatory mediators. And on this picture also we can see interaction nose and lower airways, which possible mechanism we see. During mouth breathing, we see decreased air warming and humidification, particle and irritant trapping, and nitric oxide. Also, we talk about drainage of inflammatory material. When we talk about lower airways, you can see central sensitization and nasopharyngeal bronchial reflex, and systematic propagation of nasal inflammation. When we talk about inflammatory cascade, it's very similar in patients with allergic rhinitis and asthma, because diseases have common triggers and similar inflammatory mediators. In asthma, inflammation of lower airway causes bronchoconstriction and airway hyperresponsiveness, and in allergic rhinitis, Ig-mediated inflammatory disorders of nasal membrane in response to allergen exposure. And when we talk about cells that take part in this inflammation, first of all, mast cells that bind with immunoglobulin E and release preformed mediators that lead to activation early phase response. Eosinophils, also very important because they activate late phase response, and T cell that produce cytokines also activate inflammatory mediators and lead to development late phase response in this group of patients. When we talk about inflammatory process in mucous, you can see allergic rhinitis, nasal mucus, and in patients with asthma, bronchial mucosa. And we see this is eosinophilic infiltration. This is very similar in patients with allergic rhinitis and bronchial asthma. On this picture, we can see early and late phase response in patients with allergic rhinitis and asthma. In this part of picture, we can see upper airways. This is early phase response after allergen challenge and late phase response. And we see this is the hours after allergen challenge. In lower airway, also we see the similar changes. We see FEV1 changes in lower airway after challenge of allergen. In the same period of time, we see reaction that decrease FEV1 in early phase and also decrease FEV1 in late phase after allergen challenge. So, in early phase allergic reaction, we see immediate symptoms due to mediator release after minutes to a few hours after challenge. In allergic rhinitis, we see such symptoms as rhinorrhea, sneezing, and itch. In asthma, we see bronchospasm, wheeze, and dyspnea. In late phase, usually after 4 to 12 hours after allergen exposure, due to inflammatory cell such as eosinophils, T lymphocyte. In allergic rhinitis, we see symptoms nasal congestion. In bronchial asthma, we see increased bronchial irritability and inflammation with increased tendency to asthma, phlegm, and increased severity. And asthma and rhinitis are manifestation of one syndrome, the chronic allergic respiratory syndrome. Also, we see genetic links between asthma and rhinitis. And we see overlapping susceptibility loci, the C11 and LRRC32 region on chromosome 11q13.5 is associated with atopic dermatitis, asthma, and allergic rhinitis. And this loci very important in allergic marsh. And those patients whose allergic rhinitis was severe or poorly controlled has worse asthma control and tended to have more persistent asthma than those with mild or well-controlled rhinitis. So it's very important to treat patients with allergic rhinitis, with symptoms of allergic rhinitis. In addition, bronchial hyperresponsiveness can be present in patients with allergic rhinitis without clinical evidence of asthma. So in patients with allergic rhinitis, we use spirometry test to see bronchial responsiveness or see first symptoms of bronchial asthma. Prompt and effective treatment of nasal disease can have a marked effect on preventing the development of asthma. And we must remember about this because large percent of patients with allergic rhinitis, after rhinitis, we see development of bronchial asthma, and prevention development of asthma is very important on our patient. Treatment of rhinitis has a potential to reduce asthma symptoms to such an extent that treatment with asthma medication may be unnecessary in some patients. And in conclusion, we must said that there is compelling evidence of a close relationship between the upper and lower airways in asthma and rhinitis. Similarities between the two conditions occur in the nature of the inflammation present in the target tissue. Differences in two conditions arise largely from the structural differences between the nose and lung. Subjects with allergic rhinitis have an increased risk of development asthma and may form a suitable population for secondary intervention to interrupt the allergic march. So we must treat our patients with allergic rhinitis. We must prescribe the needed medication to prevent development of asthma or increase asthma in patients with allergic rhinitis. Thank you for your attention.